Thank you so much, and thank you for the invitation and this amazing venue. So I clumped both my talks into back-to-back into the slide deck, and so we'll go through that. And so what I'll talk about is the vascular EDS natural history study, as well as arteriopathy in the splenic arteries and people living with vascular EDS. These are my disclosures. And I am sorry that I have to go back and forth just to see my slides, because unless, do we have them somewhere here? All right, how about I do this so that you don't need to look at my back. Okay, so we'll start with the vEDS collaborative information. And this really started back in 2012 when I got involved and realized that a lot of the literature didn't have as much detail as I'd wanted to see. And some of you have heard me talk about this, and for some of you this will be a newer story. So for those who have heard this before, please bear with me. But basically, I wanted to have a better understanding of the genotype, phenotype, and how that relates to surgical repair, specifically in this population. And also specifically, because we wanted a more natural, complete natural history study, I also wanted to involve the patients in understanding their research priorities, because getting patients involved was the key to addressing such a rare condition. And so we started with patient engagement back in 2017, where we convened with the community to understand what their needs are and how they thought about research. And really this way of research methodology is to work with patients as collaborators, not as cases. So that has evolved over time, as well as a research area in medicine. And you can see that we've created the vEDS Collaborative, where we brought together a lot of the patient advocacy groups as well as patient communities to come together to do this work. So what we've learned from this community is that there was substantial frustration by lack of knowledge among physicians. This is an ongoing theme, and you just heard that from our last patient who felt that that was a substantial challenge. But what we've also learned is that 93% of the people that we surveyed at that time said they're willing to share their medical records with us in order to help other people. And it's not unusual, actually, to hear that from patients while they say if there's anything they can do to help others. Even more recently, I had a mother who lost her son in his 30s and called me after the fact because she found my number in his phone to say that this would be their wish to at least help prevent so that another parent doesn't have to go through that. So that drive and that desire is definitely strong. So we created the study. We called it the vEDS Collaborative Research Study at the time, and now it's been rebranded to the vEDS Collaborative Natural History Study. And Peter and I started this at University of Washington. And the study itself, the consent forms were designed by the patient community in collaboration with us. And a couple of things that they wanted to also see is to make sure that we're enrolling children, so not to exclude children from the study, and also to have the capacity to enroll their loved ones who have passed away, because again, there's information there that we don't want to have that lost. And as you can see, at the time when I left University of Washington, we had 267 people who were enrolled prospectively, and then we harmonized that data with Peter's original data, and so the whole database had over 1,500 individuals with genetically confirmed vascular EDS. We have now moved the study to Oregon Health Sciences University, and we're waiting on the data sharing agreement between University of Washington and OHSU, and we're continuing to enroll people in that study. We also, since we were revising the IRB anyways, we expanded it to include vEDS-like conditions, so that includes everybody who has the rare types of EDS, as well as Loeys-Dietz and Marfan syndrome with arteriopathy, because that population is also not as well described in the literature. So I'm just going to highlight some lessons that we've learned. But we started exploring sex differences between males and females in the cohort. You can see this is 414 people where we were able to look at their data. And you can see that there are sex differences in survival. And this is not surprising because across the board, females live longer than males, generally speaking. And even within vascular disease, we see that as well. So that was not particularly surprising there. And then you can see here that the males in this cohort in general are younger at the time of enrollment compared to females. And then in terms of aortic and arterial pathology, if you look at it as a big cohort, you can see that there's not big differences in percentages, but if you look at it by vascular bed, what you see is that the males are more likely to have arterial involvement in each vascular bed, with the exception of the carotids. And that's specifically because carotid cavernous fistulas appears to be more common among females compared to males. But when you look at the other vascular beds, it seems to affect the males more than the females. Other things that we've learned is that vascular EDS is a progressive disease. One of the things about vascular EDS mythology, if you will, is that there's no way to predict when an event will happen. And that is true in a significant portion of the patients. However, there are also people who have progressive disease that we can pick up on imaging, and you can watch the aneurysms grow over time. So it's not always a surprise when something is there. So this argues towards why it's relevant to screen people and to look at their vasculature, because you can see findings of abnormalities that can progress over time. And this is an example of one of my patients who I followed over time and then eventually fixed her aorta. And this is her post-repair CT scan. This is another example of somebody who had a null variant, and it's quite relevant because at the age of 36 had a small iliac artery aneurysm on the right, but then over time you can see it grew up to 7 centimeters, which is quite large for somebody with vascular EDS, but this person had a null variant, so that's also relevant because even in like the normal population, that is a very large iliac artery aneurysm. And he did not have rupture, but it was symptomatic and underwent successful repair. Other things that we've learned is that people have unique morphology of the abdominal aortic aneurysm as well as the common iliac arteries, where they have preservation of the origins of the iliac arteries, where they appear to be normal in size, and then they flare in a bell-bottom configuration above the bifurcation. And then the abdominal aorta, when it's involved, has what we call a long neck. And I don't have a marker, but basically the area below the renal arteries is quite long and appears to be normal in size, and then it flares above the bifurcation. So you don't really see that with atherosclerotic disease, so it seems to be something that we're seeing uniquely in vascular EDS. And it may be that the other subtypes present like that, but I have not seen their imaging to comment on that. But within vascular EDS, I thought that was an interesting finding. Other things that we've noticed over time, and this is from the study as well as from my own experience, is that the tissue quality in the OR is variable by type of variant. And that's not surprising. I mean, previously it's been described that people with null variants live longer and have a milder phenotype. And even within people's amino acid substitutions, if you're large amino acids versus small amino acids, there's variation in the tissue. So that's not a novel concept. But really, in terms of how does that translate surgically, it seems to also translate surgically where the tissue integrity is variable. And this is an example of how we take that information. So here's one of the patients who was enrolled. He has a Sherene, small amino acid substitution, and he underwent an EVAR at an outside hospital prior to the diagnosis being known. And to the surprise of the surgeon at the time, the vessels, of course, were fragile and had dissections in the external iliac arteries and the common femoral arteries. So you take that and you contrast it to this person who also had an EVAR prior to her diagnosis being known, but she was older at the time and had an EVAR, she had a null variant and did really well and with excellent what we call remodeling. And so if you look at the picture of the top 2 layers where it says 3.3 and then the one next to it, the aorta actually shrunk and healed around the endovascular graft. So classically, we tell people in general not to put EVARs or stent grafts in people with genetic conditions because of poor healing potential. However, what we're seeing is that in some subpopulations, they heal very well. So this was quite useful in this case because this is her brother who then saw me in clinic with a discussion about whether or not we should do open versus endo, and did endo, and he's done really well, similar with remarkable remodeling. So where are we now? Well, one of the things, this is what I talk to people about, is to think about precision vascular surgery. And so all the vascular residents know that if they're going to come to me with a patient, they need to not only tell me what kind of variant they have, but what is the exact genetic notation. So even when I look at the literature and I'm on some of the case, I'm an associate editor in one of the case reports in vascular surgery, so I always send it back to the authors and say, please put the genetic notation, because I think that does matter. So I do harp on this precision vascular surgery, not only in case reports, but also clinically speaking. And this is my conceptual model of how I think about the integrity of tissue from a surgical perspective. If we're going to take FBN1 as our comparator, I'll put it as the strongest. And then what I found is that people with large amino acid substitutions in COL3A1 have the weakest tissue. Obviously, this is my sort of interpretation of how the tissue handles in the OR, but I'm curious to see how that evolves over time as people start paying attention to what variants they're operating on. All right, so now we're switched to the splenic arteriopathy. So this is the first paper from the vEDS Collaborative Natural History Study, and it is a cohort of patients specifically who have splenic arterial pathology. And the goal was, as I go through these data, the goal is to create papers that are specific to each vascular bed. So rather than saying, yes, they're at risk for dissection, this is more specific, like starting with, for example, the carotids or the iliacs or the abdominal aorta, so that when a patient has vasculitis can come in and says, I have splenic pathology, then we can give advice as to what to do. So this is the paper and just came out recently with a lot of detail. But what we know prior to that from a couple other papers is that splenic pathology appears to be present somewhere in the neighborhood of 15 to 20% of people with vascular EDS. And so we, and then including these case reports of splenic rupture as well, which I'm happy to say that we have not seen that in at least our series, but there have been case reports also describing that as well. So the study design is we took the harmonized data set of 1,500 people, and this is for people who had care between 1992 and 2021, and so that included, like I said, Peter's original cohort, as well as the University of Washington cohort that I took care of, and then the vEDS Collaborative folks. And of those individuals, you can see that 88 had splenic arteriopathy, and this is anybody with aneurysm, pseudoaneurysm, dissection, thrombosis, or rupture of the splenic artery. And you can see that the mix was 50% male, 50% female. The majority of our cohort was of Northern European descent. We have very few people of, underrepresented in medicine cohorts, and that's a whole other discussion. But the mean at the diagnosis was around 37 years, and you can see that the median follow-up was around 8 years, up to the longest follow-up was 14 years after their original event. And this is the genetics of that cohort. You can see 61% had a family history. And then you can see that the largest group, if you will, were glycine to arginine substitutions, followed by glycine to aspartic acid substitutions, and then serine substitutions in that group. We had some exon skips, and then there's the rest right there, and 9% were null. In terms of original, how they initially presented, you can see that, in fact, 17% were diagnosed with vascular EDS in the post-mortem period, so they had ruptured and had interventions and died subsequently to that, and then they were diagnosed. But you can see that half the cohort of the 88 presented with ruptured splenic arteries, and then there's a group that we weren't sure how they presented because it was never captured, and then some were incidental, and some were, 12% were found on screening imaging. We wanted to understand, is there a difference between people who presented with ruptured splenic arteries and non-ruptured splenic arteries? And you can see that, again, the group was 50-50. In terms of the age itself, people with unruptured splenic artery pathology were older and were older at the age of splenic artery pathology itself. And then what was interesting is that the vEDS diagnosis was less likely to be known in the people who presented with ruptures. And the corollary to that is that people who had unruptured aneurysms were discovered after the diagnosis was made. And then easy bruising was the only other sort of in the minor diagnostic criteria that was different, where people who had ruptured splenic arteriopathy also had more easy bruising that was documented in their history. And that could be an ascertainment bias in the way it was recorded, or it could mean something, but this is what we had found in that relationship. There was no difference in the genotypes between the two groups, which we were hoping to see if there was a difference, if somebody had a large amino acid substitution, were they more likely to rupture, but that didn't pan out. In terms of intervention, you can see that 34 patients, about 40% of the population, had some intervention. And in the 34 patients, there were 40 interventions, which means that some people had multiple interventions related to the splenic artery itself. And that's comes out to about 6 patients, or 18% of the cohort. And this was 21 open operations and 18 endovascular interventions. And all the endovascular interventions were embolizations, and that's where you go and you recoil the artery itself and basically to stop the flow. The other thing that's interesting, because this is a long horizon in terms of medicine history, if you will, that way of intervening mirrors how the management of splenic arteriopathy has changed over time in general, where we have moved away from open interventions for splenic arteriopathy to endovascular. So this was not necessarily unique to vascular EDS, but more a reflection of the technology evolving and how it's being adapted in this patient's population. In terms of the open surgical repairs, there were 21, and 10 of them included splenectomies. And then of those, those were predominantly in people with ruptured splenic, there was a report of splenic rupture, and then mostly in splenic artery ruptures, and 19% had intraoperative mortalities. And what was also interesting is that one patient developed an arteriovenous fistula 2 years later in the residual portion of the splenic artery and vein that they had left. This is obviously not meant to necessarily see, but this level of detail is in the paper. So that includes all the genetic variants and exactly how long the follow-up was and what the interventions were. So for anybody who wants to geek out on data, this information is available in the paper. In terms of the intravascular, like I said, all of them were embolizations. And of those, you can see that half of them actually had ruptured splenic artery and underwent successful embolizations. There were no deaths associated with this procedure or no access site complications. And this is really relevant because that means you can do this safely. 4 patients, however, had new splenic artery aneurysms in whatever portion of the artery that remained unembolized. So that's also educational in terms of knowing what kind of follow-up that is needed. And again, similarly, the data are available in the paper. So here's a couple of examples. This is a person who had screening and had a known diagnosis and was followed, and you can see their CT scan up in the upper right corner at 3 months prior to their splenic artery rupture, and it was normal at that time. So that shows you the limitations of actual surveillance. But when that person developed sudden onset left upper quadrant pain, they called and said, I'm having sudden onset left upper quadrant pain. We brought them in, scanned them very quickly, and performed the embolization, and they were able to go home. So it was very successful in that case. And then this is another example of why surveillance matters. So this is a person who had embolization in their 20s during after a motor vehicle crash. So the diagnosis was not known at the time, but then subsequently had the diagnosis and underwent multiple operations, including a perforation of the sigmoid colon that required a colostomy and then a takedown, so had multiple abdominal operations. But this person, you can see they had a normal looking remnant of the splenic artery, but a year later on surveillance that had already grown to an aneurysm. So we did set him up for a repair. In this case was endovascular. And what was interesting is because he already had the embolization, obviously, so the main route to where we're going to embolize the artery was not available. And so we had to think about alternative routes via the dorsal pancreatic arcade to get to that portion of the artery. And you can see the images here. And then we were able to use glue, in this case, to embolize that artery. And in his case, this goes back to, again, the endovascular options. We talk about open exposure and repair of the arteries. We are working on a paper specifically to say how best should we manage the femoral artery. Should we do it percutaneous versus open? Currently, the recommendation is open exposure and repair. My bias is, I think, if they're small size caliber sheaths, like 4 French or 5 French, they'll do okay with percutaneous, whereas if they get larger, they'll need open exposure and repair. These are the guidelines for the Society of Vascular Surgery for all the aneurysms, and this is relevant to anchor the discussion about how we're going to approach splenic arteriopathy. So the guidelines say wait for the splenic artery to be greater than 3 centimeters if it is a true aneurysm. I think that's too large for people with vascular EDS. So in the paper, we made the argument to say around 1.5 centimeters seems to be a reasonable size. Obviously, we don't want to embolize all splenic arteries because that was another question the vascular surgeon said, well, should we just embolize them? And what we found is that the proportion of the people, the risk-benefit does not justify in a normal size artery. But certainly if they're growing over time, that is something to consider. And then in terms of baseline surveillance, I went back and reviewed the ACC and AHA guidelines, and really there were no strong statements because we still don't know how frequently we should surveil folks. But in general, I do obtain a baseline CTA or MRI from neck to pelvis when I first meet somebody. If they have pathology, I'll repeat imaging at 6 months. If they don't have pathology, I'll repeat it at an annual surveillance. We've talked to people about every 2 years, but in the United States, that seems to be challenging to expand the follow-up beyond the year, just in general, because people like to have a certain month that they know every calendar year that they're going to come back for follow-up. So that's, could always be a good point for discussion. Obviously, surveillance doesn't work when you have spontaneous retroperitoneal hemorrhage or when you have dissections, because these, to date, we don't have a way to predict them as we stand. In terms of prophylactic repair, I do think it is feasible in certain circumstances. So for splenic arteriopathy, I think now we've shown that this is possible if somebody has pathology and it can be done safely. And really the recommendation is to avoid open operations for this population for splenic arteriopathy, and for specifically try to go to endovascular operations because the outcomes are superior, at least from what we had seen. And I mentioned the access site considerations. Other things to consider for the endovascular, this is really important, is the gentle wire manipulation going across the aortic bifurcation. This is a great example of somebody who had basically tearing of the bifurcation of the aorta during wire manipulation for carotid cavernous fistula specifically. So this can happen, and so that's why when we approach them endovascularly, we're very gentle, we use very soft wires, we're watching everything. So the things that we normally do, we do with ultra care in this population when we know the diagnosis. The other concept is the permissive hypotension. So when they do show up and they are bleeding, this is a really important concept to not over-resuscitate them with blood and fluids as long as they're mentating and can keep talking, even if the pressure is low. If they are mentating, we want to practice permissive hypotension. And there's a lot of literature in vascular surgery other than vascular EDS showing that this is the preferred approach in people who have ruptured aortas or ruptured arteries, and people tend to do better with that. So I think that rule still applies to vascular EDS, and we're very careful about how much fluid we give folks when they are in the hospital for that reason. So again, this is the largest cohort so far of splenic arteriopathies, and our hope as we continue with this natural history study to go through every vascular bed to be able to comment about what specifically to do for those patients when they have pathology in those specific vascular beds. And obviously, at the end of the day, collaboration between the team members is really important. They do still require multidisciplinary care. That case that I showed, we did it with our interventional radiologists in collaboration, and certainly had a lot of everybody rallied around the patient. So I do think that makes a difference in terms of the outcomes. So thank you for your time and attention. And these are the people that have participated in this.